Hi, everyone. Good morning, and I guess in 32 seconds, good afternoon. We're going to switch gears, talk about radiation. I'm going to partner with Keith Cengel, and I'll tackle part of radiation, and he'll do the rest. Disclosures, NIH funding, and varying medical systems. All right, so we recently, MARF actually was a leader along with the International Association for the Study of Lung Cancer and the NCI, developed a consensus on why we should use radiation, when we should use it, how effective it is for patients with mesothelioma. And we came up with kind of broad generalizations of why to use radiation. That's really going to be the focus of what we'll talk about today. First is for palliation to help symptoms. Second is after surgery. And we've just heard there are two main types of surgery. One is to take out the entire lung, an extrapleural pneumonectomy. After that type of surgery, we're generally giving radiation to all patients. And generally it's easy to do that. The lung's taken out, there's an empty cavity. We can essentially give radiation with immunity, not cause a lot of toxicity, but really help to sterilize any disease that could be left behind after surgery. Increasingly, though, we're doing lung-sparing surgeries, extended pleurectomy decortication. For those patients, we really need to assess how effective radiation is, and I'll spend more time during the talk about that. One group is looking at doing radiation in a big volume before surgery, I'll mention. And then we'll turn it over to Keith to talk about definitive radiation in people who are not surgical candidates, using radiation as salvage to essentially, spot weld areas that have progressed or recurred after surgery, after chemo or immunotherapy, and to enhance the immune system for patients getting immunotherapy. All right, so first starting with palliation, there are several reasons you can use radiation. Many patients, as you know, present with pain or breathing challenges with pleural mesothelioma. The pain could be from invasion into the chest wall. They're very sensitive when you invade the ribs, the nerves, etc. Radiation is very effective at controlling that pain. Somewhere around 85 or 90% of patients, if we give radiation to an area that's causing pain, they have a pain response. The pain response could be dramatic, or it can be at least modest to get lower doses of narcotics or even off narcotics, but still needs to just be managed with Tylenol or something like that. About a third of patients, though, have a complete response from radiation, and the radiation's typically delivered in just 1 or up to about 10 days of treatment. So very, very quick to do, minimal to no side effects, which is nice, and typically we give a little bit higher dose per day specifically for mesothelioma to help symptoms. It also can be used, which you don't focus on here, but for breathing symptoms, if there's a bulky area of disease that's causing compromise of breathing, the radiation can help. Sometimes patients present with neurological problems from the tumor getting close to the spinal cord. Radiation can also help with that as well, and bleeding. All right, so moving to the combining radiation with surgery, one group in Toronto is really looking at doing radiation before surgery. Now, this is really specific to patients that have their entire lung taken out. And the reason is if we give radiation to a big area in a short amount of time, there can be some risk with that. Typically, radiation is given every day, Monday through Friday, for several weeks. This group has actually looked at just 5 days of radiation, essentially blasting the chest cavity to try to help make the surgery easier, more effective, and better outcomes after surgery. But as soon as they do that, they then take out the lung just a couple of days later. And the results are quite good. In people with early stage disease who they don't see have lymph nodes at the time of surgery, by giving radiation first, it looks like the outcomes are very, very good. Don't want to focus too much on numbers today, but this really kind of doubled or more what we would typically think of in a surgical population. So it's a very, very impressive result. Again, these patients are a little bit earlier stage, but a very nice number to see. More commonly, though, people are now getting lung-sparing surgeries, as Dr. Freeberg earlier mentioned. To do that, we can't just blast the radiation. There's too much risk that now the radiation itself can damage the lung. So we really need to come up with relatively complex ways to deliver radiation in people with an intact lung. We really want to, as Keith said when we worked together at Penn, you don't want to throw out the baby with the bathwater. We don't want to treat the entire lung. We want to treat the pleura and the lining of the lung. So how do we do that? Our team at MSK actually developed a technique that's now applied nationally where we can really spare the lung itself, and certainly the normal healthy lung on the other side, but really focusing high doses of radiation to disease, particularly after surgery. So this is kind of a picture of what this looks like. It ends up being a big area, as you can imagine. The lining of the lung extends up above your collarbone, and it extends down into the abdomen. You can feel below where your ribs are, you still have some lining of the lung. So we need to treat this whole area, but we can do it pretty safely now with more advanced technology. So this technique was born out at MSK and was conducted with a multi-center study, including MD Anderson, where we looked at giving radiation to the entire chest cavity. Of the patients that had this technique, 27 patients, only about 7% had an appreciable toxicity to the lung. So it's actually nice to see. Older versions of trying to treat an intact lung, that number would be many orders of magnitude higher. So it's really nice to see that we can do this. And in doing that, we can really mitigate or delay the time that the cancer takes to come back. How does that impact survival? Well, that's being tested in this trial. So this is a big trial. It's the first cooperative group trial in a surgical population, specifically looking at a radiation question. So we're excited about that. It's being run through Energy Oncology. And this is for all patients with either epithelioid or biphasic pleural mesothelioma who are surgical candidates. They would get a lung-sparing surgery with or without systemic therapy, a lung-sparing surgery and systemic therapy, and then they're randomized to receive or not receive radiation. Again, there are some risks with radiation as far as getting some inflammation of the lung that can lead to some breathing difficulties. So we really want to make sure that this type of treatment is improving survival before we do it routinely on all patients. So this trial is trying to answer a question and really see if radiation can double survival in patients who have already had surgery. All right, now this looks complicated. I don't want to go too much into a physics slide, but there is a new type of radiation. This will set the stage a little bit for some of the definitive radiation talks that Dr. Cengel will be talking about. Just if you kind of will humor me for a minute, if we want to treat a tumor with 100% of our radiation dose, this is the radiation dose, 100% here, and the tumor is deep in the chest, say at 20 centimeters, with traditional radiation, which is this line, we send the radiation in, it builds up, and we get our full dose a couple of centimeters into the skin, and then the radiation keeps going through and through the body. By the time it gets to the tumor, though, most of the radiation's actually been deposited in your normal lung and all your other organs, and that's why you can see side effects from radiation. Proton therapy is a newer type of radiation. It's been FDA approved for a little over 30 years, but there haven't been many centers until the last few years. Now there are about 40 centers in the country, including one here in Chicago. But what protons does, it allows you to have less radiation at the entrance. We send the radiation in. Because it's a heavy charged particle, we can tell it to give 100% of the radiation where we want, where the tumor is. And then we can actually have all the radiation completely stop. So now we get literally zero radiation beyond the tumor. So all the normal tissues beyond where we want to treat, the lining of the lung, are completely spared. What's beyond that, it's your heart, your esophagus, all these critical structures. So it's a safer way to deliver radiation for patients. This is a picture of what it looks like a patient we treated. You can see that they had a bulky kind of pleural area here sitting between the chest wall and the heart. This is the heart here. We're at the bottom of the chest, so you're starting to see a little sliver of the liver. To treat this, even with the most advanced types of radiation, we're really giving radiation to most of the chest cavity, but the whole heart gets treated. And you can see toxicity from that, as well as toxicity to the esophagus down here, trouble swallowing, or even breathing trouble from radiation to the lung. With proton therapy, you can conceptualize it. The radiation comes in, hits the area we want, and then it completely stops. So now a patient will never have trouble swallowing. They'll never have the same breathing or heart problems that you would have seen with traditional radiation. Why that's important for mesothelioma, I showed you the pictures that we need to treat a really large area in many patients, extending from the whole hemithorax essentially. In doing so high up, giving proton therapy, we send the radiation, we stop. Again, the heart is spared. The other lung gets literally zero radiation, and the other lung is actually a driver of toxicity. After having mesothelioma on one side and maybe having surgery and other treatments, the lung on your side that's affected is never perfect, but you really rely on the other lung. And so we really want to prevent any damage to that lung at all possible, and protons can do that. Lower down, where the lung keeps extending into the abdomen, we can really hollow out the area where protons is going and completely spare all your bowel, the liver, the kidney, unlike traditional radiation, where you see kind of radiation dose going everywhere in the abdomen. So you won't see the nausea and the other liver problems, et cetera. And we could even treat, which is really new to proton therapy, we can treat bulky tumors. We used to really only be able to treat with this technique in the post-op setting when there's very minimal to no disease left after surgery. But with proton therapy, because we're able to spare normal tissue, you can see how thick of a rind of disease this patient had, including disease in the fissure. And we're able to really just isolate the area we want to treat, completely spare the lung in between, completely avoid radiation to the heart and the other lung. So technology has really advanced over the last, really since 2016, where we're able to deliver what's called intensity modulated proton therapy to do this. So we had an experience at my former institution at the University of Maryland where we treated 16 patients, and just to focus on the bottom one, the patients really sailed through with very little toxicity despite being heavily treated. But just focusing on, I know these numbers are a little hard to conceptualize, but we generally say if we can keep the healthy lung to less than 7.5 gray, our unit of measurement, it's unlikely you'll get side effects. Even with the best of photon traditional radiation, we're barely under that number, 7 gray. With protons, we're essentially at 0.3 gray. So we really can completely eliminate the toxicities there. The heart's less and the liver's less as well. And then lastly, before I turn it over to Keith, just want to talk about another type of treatment in a radiation oncologist's armamentarium, and that's tumor treating fields. So these are electric fields that actually can disrupt cancer division. We know that all living cells, cancer and normal, contain ions, polar charges, etc. You can have those, and those charges we know can be influenced by electric fields. So tumor treating fields, which are low intensity, intermediate frequency, alternating electric fields, can actually be placed on the chest cavity and disrupt normal cells or cancer cells. The frequency is specifically picked to correlate with the size of a mesothelioma cell. So now the tumor cells are disrupted, but the normal cells are unaffected. And what that looks like, you essentially put a pad on and you put 2 on, so either front and back or side to side, and you have an electric current going through the chest. And this was tested in a phase 2 trial called the Stellar trial, where they looked at 80 patients with mesothelioma. Patients received standard of care chemotherapy with this device. And patients who wore the device, the survival seemed to be better than we've seen in standard chemotherapy trials. Now, this was done before immunotherapy. The numbers are even better, of course, now with immunotherapy. Of course, adding radiation and other things, we can have the numbers even better. But the nice thing to see is the survival was better than was really expected when this device was applied. And the really nice thing is that it didn't really add much in the way of toxicity. So, we think of systemic toxicities with chemotherapy. Despite this being systemically applied on the chest, we didn't see any added toxicity systemically. The only toxicity that was seen was actually some skin irritation. That was really from the adhesion of the device itself, the stickiness on the probes. And about 5% of patients had more than a nuisance. If you put a Band-Aid on and take it off, the skin's a little irritated. That's what had to happen for this device, and that's the same thing. There are a lot of ways to manage that, and so it's something that, as radiation oncologists, we can see skin effects and we can manage pretty well. So based on just an 80-patient trial, this device received FDA approval in 2019. So it's the first device in almost 2 decades to get FDA approval for mesothelioma. So it's a very good option for patients that are getting standard of care cytotoxic chemotherapy. So in summary, radiation is very good at palliating symptoms, especially pain. If patients are going to have a surgery where they take out the entire lung, they can be considered for radiation before the surgery in very select cases, especially if they're early stage and node negative. In patients that are having a lung sparing surgery, that extended pleurectomy decortication, we would generally use radiation after that. We know that it can help with preventing the cancer from coming back. Testing it on its impact on survival is currently being done in a large phase 3 trial, but we do think that there's a potential to significantly change the standard of care, and patients essentially uniformly, if they get that surgery, they should be getting radiation as well. Proton therapy is probably the best way to deliver that, or some of the radiation that you'll hear about in the next talk, because it can reduce side effects since we treat less normal tissues. And then tumor treating fields in patients that are getting standard chemotherapy can be a great addition without adding a lot of side effects for patients. So now you'll hear about definitive radiation, salvage radiation, and the effect of radiation on the immune system.
Thank you very much.
All right. So everything you always wanted to know, but were too afraid to ask in 7 minutes or less. Here are my disclosures. So there is an accurate self-portrait up at the top left of me doing radiation therapy. So I like to think about radiation in time and space, and so I was sort of try to conceptualize what we're dealing with. We have a problem of space. We have a tumor that surrounds a lot of really important normal tissues as kind of a thin layer. And so we need to find ways to spatially fractionate the dose and then thinking about how do we adjust the time component. So traditionally we've done this by giving a different amount of dose per day, what we call fractionation. And then I'll talk very much at the end a little bit about some of our dose rate modifications with flash radiation. So as Dr. Simone mentioned, you can see early on we start with very simple sort of fields. You can come from multiple different directions. You can kind of do some shaping. You can see here, this is what a multi-leaf collimator actually looks like in action. So that's shaping the field from each side. And once we develop the ability to do that electronically in real time, we start to be able to do this, what we call intensity modulated radiotherapy. So the radiation therapy Dr. Simone was showing for the original imprint study is IMRT, which is pretty sophisticated stuff, except, and there's always a caveat on everything, you can see what ends up happening, which is to get that conformality in space, you're going to spread dose out. And so you smear dose out elsewhere. So it's not, and that's just the nature of the X-ray because it has exit dose. You can get really fancy with that, and for very small fields, this works extremely well. So a spinal metastasis, you can give very high dose, a lung metastasis, liver metastasis, things like that, you can do that. But again, if you look sort of back and forth, if you show just the 90% dose, it looks like this lovely little sort of spot, but when you kind of look at what it really does, it's actually spraying quite a bit of dose, which can have effects. So the idea of protons now in the modern era is we pencil beam scan. So you can see we're basically painting that volume layer by layer by layer by layer. Now, that looks, of course, extremely good. And if you were a block of wood made of perfectly homogeneous stuff that wasn't moving, that would always be better. And so to the extent that you don't resemble a block of wood, protons, we sort of are degraded in our ability to know where it stops. And that is what really causes us the trouble. So most important thing, if you get nothing else out of this, there is no best radiation. There's only where your tumor is, and sometimes you know, photons are great and sometimes protons are better. So how do we think about temporal fractionation? That's really the meat of this. So essentially cancer cells don't heal between treatments as well as normal cells. And so when we're treating very large areas, say, there we go. So we're treating the whole chest in like this imprint-like technology. We need to go slow, and we need to give a little bit of radiation every day, 5 days a week, and let the normal tissue kind of keep up. When we're treating much smaller areas, we can go in a much bigger dose per fraction and get things done quite a bit quicker and potentially even with more efficacy. And you know, one of the things that's happening as we keep going in this field, as our ability to spatially fractionate the dose gets better, maybe we can start speeding things up. And we'll talk about that toward the very, very end. So you can see here, RT in the definitive setting. So this means treating people who have disease. You know, this is a patient where we're treating the entire pleura. And in this particular case, you know, you're boosting sites of gross disease, treating all the areas to a standard disease. This particular patient has one kidney on the side of the tumor. There is zero chance that I would do that with IMRT. And this is one of those magical moments where you go to your dosimetrist and you're like, can you get the dose really low? He's about, how about 0? And you're like, I'll take 0, that's fine. You know, this is that patient Dr. Simone showed with the anterior mediastinal mass. And again, you can see that ability to sculpt around the heart that really can totally change things. In the peritoneum, we sort of run into a lot more trouble. The peritoneum is a much more convoluted surface. The surface of the organs are much more difficult to treat. And surgery and reoperation play a much bigger role. So we had done some whole abdomen back in the old days, which is really pretty toxic, and we may be able to come back to that with flash. But mostly now what we do is we spot weld. So for example, a patient with peritoneal disease who had a recurrence up high that was eroding into the liver, progressing on immunotherapy, we're able to spot weld that pretty well. And that really sort of brings us into the topic of the oligometastatic paradigm, which is a big 50-cent word for treating sites that grow. So, we don't need to treat every last cell. Maybe we could just treat little areas. This increasing ability to spatially conform the dose and do it in just a few treatments, so it's not terribly inconvenient for the patient, we can start spot welding. So, this is our standard oligometastatic paradigm. Don't see too many brain metastases in patients with mesothelioma, but you can do radiation all over the body and sort of think about this as almost a systemic approach. So, for example, here's a patient that we treated many times over the years with either SBRT or proton radiation therapy. Actually had, I think, 5 separate courses of radiotherapy over the course of many years. This is pre-immunotherapy, and essentially kept this patient going and on to the next line of systemic therapy. The other sort of exciting thing, and we're not sure what to do with this, we've all seen this, it's almost a little bit of a rainbow unicorn. So you have patients on immunotherapy, they're cruising along, they might have one site of progression, or they might have multiple sites of progression, and you go ahead and you use one of these highly focal SBRT-like or proton modalities to treat one lesion, and you can see other lesions starting to shrink. So this is a patient we treated years ago with meso. She was actually progressing on immunotherapy all over, but had a painful metastasis. We treated that one, and you can see here an area outside the radiation field responding over time suddenly to the checkpoint inhibitor. Again, we've done some clinical trials trying to focus in on who's the best candidate, how to make this happen better and more on purpose, and we've struggled quite a bit, but certainly it's something that can happen when you add radiation therapy. And then, what's on the horizon? So I'm a huge Halo fan, obviously. So, I sort of split my on the horizon therapies to things that are ready for prime time. Here's Master Chief saying it's go time. And there's the wake me when you need me kind of things. Maybe we're playing with fire and we should be a little bit more careful. This flash radiation is more on that not ready for prime time, we're getting ready for it thing. So if you imagine standard dose rate, protons or photons or electrons being given, and the dose rate would be something the size of the solar system here on this. We can control the therapeutic index by modulating that space. We can modulate the fractionation, the time between doses, but we have this terrible paradox. The bigger the tumor, the lower the dose, and the longer the treatment course. So this crazy idea came up, which is with some fancy modifications to the proton beamline, we can up that dose rate about 10,000 fold. So now if you just do a relative size of the spot, it's something more like that size. And it turns out it seems to put an equal hurt on the tumor, but spare normal tissue. And we're really not sure at all why that works. It was not something predicted. It was sort of a serendipitous observation. So now with protons, we can do this spatial dose. We can do some fractionation potentially, but with flash, now we can treat very large areas potentially in a very small number of treatments, and we might be able to pump that dose up so a larger area would be able to be treated. So we're beginning to explore this. There's some technical limitations. So the initial beams that we've been working with for various technical reasons have to be very deeply penetrating. So we have to essentially, if you're a big Spinal Tap fan, we had to turn the cyclotron up to 11. And we're using a beam that is a 32 centimeter depth of penetration. So the initial patients we've treated are extremity tumors. At Penn, we've utilized the fact that I have a lot of veterinary collaborators, and so the veterinary oncologists across the street are happy to enroll dogs on our trials. We're able to bring them over to the human hospital and treat them. So I enrolled 32 dogs on a study of standard versus flash protons for dogs with osteosarcoma, which we're still analyzing the data, but it looks like they're equal in terms of tumor cure and probably less fibrosis signals, at least so far, that we're seeing. There's an initial trial at the University of Cincinnati in humans, looking at humans with extremity metastases, that it's a much lower dose, 8 gray in a single treatment, but it looks like at least it's feasible and it works about like you'd expect 8 gray to look. You don't see much toxicity with that. we're now initiated, just started a trial in dogs with head and neck. So the advantage of head and neck tumors in dogs is that you can see all the mucous membranes really well, and you can watch and analyze the toxicity, and you can look at the saliva and figure out all these different things about what's really happening on the ground. So we're treating dogs with head and neck, and in this case we're using 2 separate treatments and escalating that dose up to a very high dose. And they're about to begin in Cincinnati another bony metastasis trial, this time focusing on metastases over the sort of torso to sort of start seeing, again, a pretty low dose at just 8 gray times 1. But so we'll see where that goes. Very exciting, and it maybe gives potential. And what does that potential look like? So this is that patient with the anterior mediastinal tumor. So we treated him originally with double scattered protons. You can get a little better with more fancy pencil beam scanning protons. But this gentleman came from upstate New York, and he had to stay in Philadelphia for 7 weeks, which was kind of a drag. That same treatment, especially double scattered, was really slow. We're 45 minutes per treatment. He's laying on the table with his arms up like that. If you treat this same thing with flash protons, we're thinking potentially 3 fractions, 3 total treatments, Monday, Wednesday, Friday. Each beam on for that would be 20 milliseconds. So you'd still have, 3 minutes of aiming, but yeah, the beam on time goes from 45 minutes to 20 milliseconds. So pretty quick, and potentially equal efficacy with less side effects. And I think that is a potentially game changing if this goes forward. With that, I guess we can stop for questions. My daughter is 15 now. She hates that I show this slide, but I got to be me. So questions? I don't know if Dr. Simone wants to come on up too.
Sorry.
Oh. I'm going to take that slide off before my daughter kills me.
This is kind of an academic question, but if people didn't get fatigued and resources and people's schedules weren't considered, would you do the radiation 7 days a week for 30 or 40 days?
So that's really interesting. So we did a lot with different fractionation regimens, mostly in head and neck, in the 80s and into the 90s. And one of the things we found was called the various well regimens, meaning weekendless. So you would 7 days a week, and it beat people up. Pretty, and in some of them, we really intensified treatment, and we actually saw significant, like, spinal cord toxicity. So it turns out probably that extra 2 days on the weekend really allows the normal tissues to recover fully. So I think it's, maybe thankfully for our profession and for patients that was the finding. But no, it's really interesting, and it's a sort of an important thing when we say once a day radiation. What we really mean is once a day with an every so often 2-day break, right? And that, I think it's really important.
Yeah, and it probably depends on tumor type too. So it's almost oncology lore that mesothelioma is radioresistant. That really comes from the fact that, as you saw, the big fields that we used to treat when the technology was very different and we couldn't adequately treat them. Now we have IMRT, we have protons, and what we see is actually mesothelioma is more radiosensitive than a lung cancer, for instance. And the only disease in the chest that we've seen potential benefit for doing weekendless treatment is a squamous cell, and those patients still had more toxicity. So we probably don't need to do it for mesothelioma, and it's easier on patients to get through.
Thank you very much. We're actually out of time. One more.
Sorry, just a quick question. Is there any research doing tumor treating fields in peritoneal or any consideration of that?
There's research in the body region. So there's a large ovarian trial being done, I believe a phase 3 trial that's pretty far along. So we'll have a good sense of the toxicity from it. We're not expecting much toxicity because it's been done in brain, it's been done in lung and mesothelioma. And we've only seen that skin toxicity, but we'll have an answer on at least the toxicity. As far as the efficacy, to my knowledge, I don't think there have been any studies done for peritoneal mesothelioma specifically. That's a great point, though. It's something that could be explored because, like Dr. Cengel said, we do have a tougher time with radiation, so that may be a nice way to treat those patients.